Hello and welcome to the Retina Radar. I'm Arshad Khanani, Managing Partner, Director of Clinical Research and Director of Fellowship at CRI Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. I'm joined by my good friend and colleague, Dr. David Eichenbaum, Director of Research at Retina Vitreous Associates of Florida and Collaborative Associate Professor at the University of South Florida Morsani College of Medicine in St. Petersburg, Florida. Welcome, David.
Hey Arshad, happy to be here. It's always a pleasure to talk with you. It's been years now, and we still like talking, so this is good.
Yeah, it's been more than a decade. You and I have worked together in clinical science and collaboration in so many different things. And I'm so excited today that we'll be discussing new efficacy, safety, and durability data on dosing regimens, delivery system, and emerging therapies for neovascular AMD. David, in this podcast, before we dive into the topic at hand, we usually ask some fun questions about our guests. So today, you're the guest of honor. So tell us, how did you end up in Retina?
So, how did I end up in Retina? The whole thing was a little bit of a happy coincidence. When I went to medical school, I thought I wanted to do something like you see on TV, trauma surgery, cardiothoracic surgery, something large and gory and full of machismo. It turned out that none of that stuff appealed to me in the real world, and I became confused. I did not know what I wanted to do, and I had a patient in my medicine rotation who was an ophthalmologist, and I took care of her for a couple of weeks, and she had a progressive neurological disease, a form of multiple sclerosis that was advancing, and our conversations led me to ophthalmology. And then once I was in ophthalmology, I was certain I was going to do orbit because it's a gigantic surgical specialty. And again, that didn't appeal to me. It was kind of like operating on an ice cream cone in the dark behind the ice cream ball at the end. And it was just very unappealing and sticky. And I wound up in retina because it was beautiful. It's still beautiful. The imaging was beautiful. The indirect ophthalmoscopy was beautiful. The vitrectomy with the indirect viewing systems at the time, those were novel, those were beautiful. I still have to stand back and think about how pretty it is when we get to work in the field of retina every day.
No, I mean that's so true, right? I mean, we are so lucky to be doing what we are doing, and we enjoy and we give vision to patients or maintain their vision. And I think that's the very rewarding thing for both of us here. So what about your hobbies? Tell us. I know you're part of some bands and stuff and you're into old cars, but is what is your favorite hobby?
That's pretty much it. I have almost no hobbies. I tell people I have very limited interests. I basically know a lot about eyes, a lot about rock and roll, and a lot about old cars. And it's hard to say. The music stuff is just so accessible. It's literally everywhere. So it's probably my favorite. I really like the people I've met through rock and roll, the things that I've seen, and the fact that you can take it with you essentially anywhere that you go. So I really like music, especially guitar-driven rock. Some of what they call alternative country, some of what they call indie music nowadays for the kids. And I need to spend more time picking and less time playing with eyes to get back into the guitar playing at a serious level. But it's really a lot of fun. The old cars are great too, but they're a heck of a lot less portable than the music.
Yeah, no, that's so true. And what about your favorite vacation spot?
Man, the more and more that we do this, Arshad, the more and more I love the idea of hanging out at home and spending time on the water in the pool. My favorite vacation spot is being at home in Florida, I think, at least this year. If I'm out of town, my favorite out of town vacation spot, probably somewhere where I can get outside and get moving. We have a place in Colorado, and I spent some time out there early in the summer, and I went hiking with my kids. We went on a Jeep ride. We go in the whitewater. It's nice to get outside and get truly in the wild, or at least as much in the wild as you want to be with your family and spend time together. That's what I really like.
No, I mean, Florida is a great place to live, and Colorado is not too bad either. If you like wild, you should come take a week off and come to Lake Tahoe. You're always welcome here, as you know, and it's just fantastic here too. So, okay, let's jump into topic at hand. So, we have had two great innovation over the last couple of years. We had the approval of faricimab the first bispecific antibody for retinal diseases, blocking VEGF-A and Ang2. And then last year, we had aflibercept 8 milligram, which is the high dose of aflibercept approved. So let's talk a little bit about some of the recent trial results that we have seen. So let's just focus on aflibercept 8 milligram first. Can you talk us through the 2-year Pulsar trial results and how the data is affecting the way you manage your neovascular AMD patients? I know that you were an author on the paper in Lancet for one of the indications for aflibercept 8 milligrams, and you were also in the clinical trial. So give us an overview of what we know so far and how it's impacting your clinical practice.
Yeah, it's a great question, extremely topical. We were heavy enrollers in both Pulsar and Photon, and Pulsar for neovascular macular degeneration. We were actually the highest enrolling site on the planet, partly because of our population and partly because I have an incredible team behind the clinical trial site. And then I had the privilege of working on the Lancet paper for Pulsar. So the fundamental intriguing thing about the Pulsar and the Photon trial, but we'll focus on Pulsar since we're drilling down on neovascular AMD, is that the study design was not that you have to earn extension, it's that you have to earn contraction. All of the patients who were randomized to aflibercept 8 were loaded for a couple of doses and then stretched out to 12 or 16 weeks. And they stayed there unless they showed disease activity with a decrease in vision. What's encouraging about the results of the paper is that even with this very aggressive fixed extension, the vast majority of patients remained on fixed extension and did just as well on average visually as patients who were on aflibercept 2 milligrams every 8 weeks, which was the active control. So these patients were extended to as much as twice as long as the active control group, and the visual acuity was non-inferior to the active control group, which was really remarkable. In the second year, there was the ability for the patients to extend even further, and almost half the patients got to 20-week intervals or greater. And the criteria for extension was a little bit more traditional than the criteria for contraction in the first year. So there is data speaking to significant durability in patients treated with aflibercept 8 milligrams. I think the patients who were the toughest were those who had to be contracted, and we're still trying to figure out what to do with those patients in the real world, since the label only grants us the ability to dose aflibercept 8 every 7 or 8 weeks. So the really tough patients who have aggressive disease, or the tough patients who are converted to aflibercept 8 with aggressive disease, are difficult to maintain every 7 or 8 weeks. And we probably need to think about alternative strategies for that small group of patients.
Great overview. No, I agree with you. I think it's a great ad for our field. And I think figuring out that we always have this 10 to 15% of patients with quite aggressive disease that no matter what drug you use, you need to use it frequently. And I think having that flexibility, hopefully in the future, would be great. And I know you presented first-time results from your real-world experience at clinical trials at the summit, but we'll jump on it later in this podcast when we talk about real-world data. Now let's jump into faricimab. Again, you and I were involved in the development programs early from phase 2 days and of course phase 3s. The phase 3 TENAYA and Lucerne studies were pivotal studies to get approval of faricimab. We have also published recently the 2-year data from those studies. So there's a bunch of post-hoc analysis have also been done. So we have seen efficacy and durability of faricimab in these patients with neovascular AMD. Tell us a little bit about some of the recent analysis you have seen for faricimab in patients with neovascular AMD.
Yeah, so it's really fascinating. TENAYA and Lucerne were, as most of us have discussed, a different design than Pulsar, where patients in Pulsar had to earn contraction. Patients in TENAYA and Lucerne had to earn extension with both preservation of anatomy and preservation of vision. There was also a cap on the extended interval at 16 weeks through the second year of TENAYA and Lucerne. And those patients didn't have the option the second year to stretch out longer. What's interesting is that the post hoc analyses that we've seen show that if the treat and extend criteria, which allow patients extension up to 16 weeks in Tenaya and Lucerne, were applied to the patients in that study through the second year, over half of them would have been able to extend to 20 weeks. So there's a potential that faricimab in wet AMD patients can get patients out to 20 weeks or perhaps beyond. And this is something that we have to look at in the real world with utilization, frequency of injection, and see how the patients do it. There have been a lot of post hoc analyses looking at the DME patients in the faricimab development program. And we've seen a lot of interesting things regarding differential in lesion response and imaging responses compared to the active control for the DME patients, which was the aflibercept 2. But focusing on a wet AMD, the most impactful post hoc analysis for me is the implication that the majority of faricimab patients in the phase 3 program could have actually gone further than 16 weeks.
No, I think that's a really good point. And I think the other thing, for me has been like the drying effect, right? That we have seen in head-to-head phase where we have seen better drying with faricimab. And I know the PED data has been very impressive in terms of flattening PEDs. The question is still out there, and people still are not sure whether Ang2 is doing anything on top of VEGF-A inhibition. What are your kind of bottom line points on the fact that we are actually seeing a difference by inhibiting Ang2?
Yeah, so the eye does not have an Ang2 meter and a VEGF-A meter, so we can't physically see the effect. We know from basic science piece of the faricimab development program that we're getting target engagement with Ang2. We know it's blocking Ang2. What we're trying to see with all these post hoc analyses and what we're looking at with the head-to-head data is what is the effect of faricimab versus active control of aflibercept 2, and what part of that effect is Ang2 inhibition. I think the compendium of evidence that we have, looking at what we know in neovascular AMD series, the PEDs, and what we've learned extensively from the DME series, looking at fluorescein angiography leakage differences, looking at intraretinal hyperreflective foci differences, looking at epiretinal membrane formation differences, is that there seems to be something differentiating faricimab. And I think the compendium of evidence speaks to that being the Ang2 inhibition. What we don't have and what we'd really love to have is a head-to-head between faricimab and the high molar dose of VEGF inhibition in aflibercept 8. Because the question that's unanswered is, does profound VEGF inhibition match, exceed, or not quite meet the effect of VEGF-A inhibition with Ang2 inhibition? But I do think the compendium of evidence that we have in the Tenaya and Lucerne and DME series, faricimab, speaks to Ang2 inhibition doing something. Something beneficial for the anatomy in patients with either neovascular macular degeneration or DME.
No, I totally agree with you. I think, obviously, as you said, clearly that we don't know what effect is from what inhibition, but I think as you have seen and as you said, that I think going beyond just VEGF does lead to better, macular leakage control, probably faster drying, maybe better durability. So I think, I think in the future, it would be nice to know some biomarkers that you can see, obviously, without doing aqueous paracentesis or something else to kind of know, hey, which is the patient that is going to respond very well. I mean, in all cases, I mean, when you're looking at averages, patients are doing really well with dual inhibition. Okay, let's switch gears now. Today is a great day to talk about this, David. Port delivery system with ranibizumab, also called port delivery platform, because there's new drugs being placed in this implant. Exciting sustained delivery for our patients. You and I have been involved with this for years now. We used it when it was commercially available. We have also worked on the Summit study, which is looking at real-world outcomes from commercial implants. It was recalled because of septum dislodgement issues from the phase 3 implants. And today it's back. FDA gave a green light for it to come back to the market. I think, tell us for the audience, what happened? Why was it recalled? And what was done to fix that? I think it's important for the audience to know that there was actually clear science that was utilized to kind of bring it back and fix the issue.
Yeah, so it's a great story. It's a fantastic development story, and something kind of unique in retina is we've been involved with pharmacologic development for so many years. This is device development as much as it's pharmacologic development. So it's kind of been a fun thing to be part of. As you said, you and I have implanted many patients in the phase 2 and then the phase 3 registration studies for mostly neovascular macular degeneration for me and some DME patients. I didn't implant in the DR study, and then commercially, we utilize the initial version of the implant, and then we've combined our data into the Summit trial. And of course, now there's been the green light for the ongoing trials like Burgundy and Belvedere, looking at the new and improved 2024 model of the implant, looking at novel drugs for that platform, as well as looking at phase 4 with the concentrated ranibizumab. So, what's the story? What happened? The platform was recalled, the port delivery system was recalled because basically the septum, in a larger proportion of the implants than was expected, became dislodged and fell into the body of the implant. So that wasn't expected, and that was a reason for a voluntary recall. And what happened in the intervening 2 years between the recall and relaunch, what happened in the interval is a redevelopment program looking at the bonding of the overmold and the septum to the body of the implant. And then that new and improved bonding was tested with an improved refill needle, which has a siliconized wire instead of the bare wire, which was the initial launch version. And then there was a simulation done on these new implants, replicating dozens of refill procedures. And there, in this simulation, in this simulated eye environment with simulated refill exchanges, there was a significant reduction in the dislodgement of the septum in the new and improved implant, which is now commercially available as of today and has been used restarting recently in the clinical development programs for the port delivery platform. So it's an exciting thing, and I'm excited to see it return because there is so much promise in this platform, both in the commercially approved wet AMD indication, but perhaps in other disease states and perhaps with other agents.
The benefit of sustained delivery with the port delivery platform, obviously with ranibizumab, we have, long-term data now from Portal, 4 or 5 years or longer. And I agree with you. I think it's the first device to treat retinal diseases, and I think we have learned a lot from it, not only just the device itself, but also the surgical procedure, right? Like I look at my surgeries from phase 2 latter days, and I look at the surgeries from recently, Pagoda and Pavilion. They just look much better.
No, we improve. It's like anything else that is a physical exertion, whether it's practicing a musical instrument, playing a sport, or doing surgery. We get better, and we see this. We see this in the progression of publications from ladder through ladder to portal, through archway, through pagoda and pavilion, and now with summit, we have reduced our rates of complications. And even personally, I fortunately have been part of a couple of dozen of implantations and almost 200 refill exchanges. And I managed the complications better because, we can't be more clear about this. There are issues with an indwelling implant in the eye. We've seen this with the glaucoma drainage devices for generations. And we see this over the last couple of years with the port delivery system. And the important thing is not to ignore the complications of implants, but to learn how to manage them. And as surgeons, I think we've gotten a lot better at managing them. I know individually I've gotten a lot better at managing them, and I'm much more confident in the recommendation for a port delivery platform in either a commercial patient or a clinical trial patient than I was 5 or 7 years ago.
No, definitely. I totally agree with you. And I think just knowing what to do at what time, I think, if you have a conjunctival erosion or something, which we rarely see now because we close so much better, right? With congentinons and right at the limbus with overhang. And I think if you see it, you recognize it, you avoid, a major complication by fixing, as you said, the problem. So yeah, a lot of potential. It was green lighted today. I had a patient today that has implant in the fellow eye, has been waiting, ready to go whenever, we can start implanting in the next few weeks. So I think it has the potential, but as you said, it's a risk benefit discussion. And I think the profile has improved, but obviously it's an implant in the eye. So patients need to understand, there could be some complications from surgery, even if you do a perfect surgery. But overall, I'm very pleased to see that my surgeries at least are looking much better than what they did back in the day. And I really like the new refill exchange needle. It is really smooth, and makes the process so much quicker that, what was making me struggle back in the day with ladder, now I don't struggle at all because it's so much better in terms of lubrication. So David, give us a little bit quick overview of the extension data. And I know you presented that in the past from the portal extension study where patients from ladder and archway were rolled in, and we have over 5 years of experience in terms of the benefit of sustained delivery.
Yeah, so a couple of important things. First, looking at the efficacy, the vast majority of patients, almost 95% of patients, did not require supplemental treatment between each refill exchange interval. And that's humongous. That's a procedure for a patient every 6 months, which is remarkable. Every 6 months, duplicating monthly ranibizumab, the goldest of the gold standards, essentially. So it's a remarkable efficacy outcome for the patients with port delivery system. We also saw that the rate of problems such as conjunctival erosion or exposure of the implant decreases over time. It doesn't go away, but most of the exposures occur much closer to the implantation, probably related to healing and conjunctival contraction, than they do many, many years out. And between the incredible efficacy, the stability of the results, and the lessons that we've learned about safety, it's important for doctors who are considering this to know that we've fortunately learned a lot more about the port delivery platform while it was in recall over the past 2 years, while the portal study was continuing to collect data. And there's a profound amount of support, not just from the company, but from their colleagues in the community who have had a lot of investigational and the limited commercial experience with the implant when it was available, following approval initially. So there's a lot of help out there for folks who are interested. And I can confidently say that any retinal surgeon who can do a retinal detachment repair or a scleral buckle can do one of these implants with incredible success using skills they already have.
No, I totally agree with you. I think it's a unique surgery, more work on the front of the eye and the back of the eye. And, you and I do so many difficult cases. This is straightforward. It's just that you got to follow the instruction for use and just follow the steps and take your time. And I think you end up with a beautiful surgery after, just learning the process. And there's a lot of training programs out there. So yeah, I'm definitely, back with it. I have patients who have been waiting, and it will be great to be back in terms of helping patients decrease the treatment burden, the fear of injections. We all have those patients, and really, optimize outcomes. I think the data that you discuss, I think we have not seen efficacy this good in terms of maintenance of vision for 5 years or so. And I think that's something that is promising and shows us the power of sustained delivery. And I think it moves the field forward by itself. So let's switch some gears here, David. New mechanism of action. Again, you and I are involved with essentially everything. So you've been involved with OPT 302, or now called sozinibercept. It's being studied in the phase 3 Shore and Coast studies for neovascular AMD. It is a novel MOA in terms of, trapping VEGF-C and D. Just give us your bottom line on why an add-on injection will be meaningful for our patients or even for physicians by blocking VEGF-C and D. What are the things that will drive that? And just cover some of the top line data from the phase 2 trial that you were
Yeah, so,
part of.
so this is a fascinating study. I really love this program because this is the only program we have looking at improving our visual acuity outcomes. Everything else is looking at improving durability, which is important. But we do have patients who could do better with regards to visual function. So what this study showed in phase 2 is that patients with treatment naive wet AMD with certain lesion characteristics, such as not having retinal angiomatous proliferation, for example, did have a suggestion in the phase 2 that there was superior visual acuity outcomes when sozinibercept was used to trap C and D in combination with VEGF-A inhibition. What we're looking at in phase 3 is combining sozinibercept with both ranibizumab and 2 milligram of aflibercept to see if that bears out in a very large phase 3 population with almost 1,000 patients in each of those clinical trials, Coast and Shore, which are enrolling patients with aflibercept and ranibizumab, respectively. Those trials are fully enrolled, and we're hoping to have top line data probably about a year from now. And if that is positive, we'll have the first drug since ranibizumab that shows a further increase in visual acuity, which would change our field. We'd have to figure out how to use it. Would it work in treatment experienced patients? How long do you have to use it in the real world to get those potential benefits? Do you have to use it indefinitely? Can you treat and extend it? A lot of things we don't know, but it would be very encouraging if it reads out to have something that could improve our visual acuity outcomes in our armamentarium. And my patient's priority is always to get the very best vision. So I don't think it would be a hardship for patients to at least start with it when they're treatment naive.
Very well said. I think exciting to have a novel MOA and first shot on goal for better vision. And I can't wait to see the data next year, and we'll see where we can utilize it. From a patient perspective, as we know, they see us to have the best vision, and I think they're all scared of losing independence. So can't wait to see the data next year. Let's move on to the last topic for today before we ask you some more questions about yourself. David, you and I have been involved with real world studies, Truckee, for Retina, the aflibercept 8 milligram data you just recently presented. Give us an overview of your presentation from clinical trials at the summit. About it was essentially the first case series of real world aflibercept 8 milligram usage, and also share some of the learnings you have seen from Truckee and far retina AMD studies.
Yeah, certainly. So we'll talk about the aflibercept 8 real world data set first. This was a small data set from our practice and a practice in Wisconsin. I've got to shout out my co-authors, one of whom is Deepak Sambara, who's going to be presenting more data from this small series at ASRS, and then Priya Vakaria in my practice, who worked with a lot of the data from our patients. And what we saw was that there is a proportion of patients who really do well with aflibercept 8 milligrams. And this was a population which was all wet AMD. 90% of these patients were switchers. It was very real world. There's a population of patients who are superbly aflibercept responsive, and they do very well with 8 milligram. They do better, they dry up, and a lot of them can extend to some extent. And a lot of these patients were switchers, who were the patients we addressed earlier in this conversation, who were difficult to treat. We also saw there were about a quarter of patients who really couldn't do as well on aflibercept 8 or couldn't extend to a point where they could be treated on label. So they really weren't aflibercept 8 candidates. Our treatment naive patients all did well on aflibercept 8, essentially. But our treatment experienced patients were indeed a mixed bag. And I think the only way to figure it out, if you have a patient who you're wondering if they're an aflibercept 8 patient, is to give it a try and see how the patient responds. Because it's similar to how there's not an Ang2 meter in the eye, there's no stamp on a patient's forehead saying, I am responsive to aflibercept, my eye would like more of it. You should give it a try and see how the eye responds, see if the extension interval changes, see if the OCT changes, see if the outer retina, like pigment epithelial detachments, change. And that's really the way we're going to have to figure it out for now. But we can't expect 100% of our switchers to make it to 12 or 16 weeks or be treatable on label, especially if they're tough cases, if they're frequent flyers. Those patients are sometimes hard to treat with any drug.
No, I agree. And I think when a new drug comes out, it's all about trying it on the worst of the worst, right? To see if there is any benefit. And I think that's something to keep in mind, is that many of these patients are so severe that maybe, it's very difficult to control disease. And do you recommend like at least doing the 3 loading doses to see the outcomes, or you just feel like the one injection will give us whether they're going to be responsive or not?
In a switcher, I think you can tell with one injection with most drugs if there's a difference. I switch them and I bring them back at the same interval and I take a look. With my treatment naive patients, I try to duplicate the clinical trials to some extent. So I do load my treatment naive patients with a couple of shots, regardless of the agent I'm using. We don't have any randomized controlled trial data on switchers, so it's kind of the Wild West out there with regards to how to treat them.
No, I agree. I think I do exactly the same. And what about some of the learnings from Truckee and far retina, I mean, I think our experience have been that adding edge to VEGF-A inhibition with faricimab, we saw better anatomic outcomes in terms of drying, in terms of PD flattening, in terms of durability. We were able to get these patients, especially the high need patients, better controlled. What is your bottom line overview of usage in your practice, as well as the data you have seen from these trials on the benefits of faricimab?
Yeah, so Truckee, which you spearheaded, has shown us that faricimab performs in the real world similarly to how we'd expect it to perform from the clinical trials. Namely, it does well, and patients improve when they're switched and do well when they're treatment naive and don't seem to need a lot of shots to obtain a good visual acuity outcome. Now, Far Retina is looking at patients with DME, and Far Retina is a database analysis looking at literally tens of millions of charts, which yielded thousands of patients and thousands of injections. And Far Retina also suggests that the mean vision change from baseline in either treatment naive or treatment experienced patients is something that is similar to what we saw in the clinical trials. And the anatomy, the response is similar to what we saw in the clinical trials. And importantly, the safety seems to be at least as good as what we see in the clinical trials. So the real world data supports the hypothesis that something is happening when we're treating patients with combined VEGF and Ang2 inhibition, and that something is positive. Of course, as we've stated before, there's no comparable data regarding aflibercept 8 yet, regarding these second generation agents, as we term aflibercept 8 and faricimab. But the data we have in the real world from 2 years and a couple of million doses of faricimab now from databases like Far Retina and real world grassroots efforts, namely Truckee, are that the drug is good. The drug performs similarly to how we'd expect it to in the clinical trials. And we are very positive regarding the outcome in the real world when we treat patients with faricimab.
I agree with you completely. I think it's kind of surprising. I think it performed so well in those switch patients because we did not have any data, right, from the trials on switch patient. It was all naive, the Tenaya and Lucerne. I think the switch patients gave us the wow effect that we actually see something else is happening, as you said, in terms of disease control and in terms of anatomic improvements, which obviously ultimately lead to durability. Okay, we're running out of time, but I ask all my guests these questions. Tell us, so far in your career, you've been in practice, I think, around 15 years or so. What is the career achievement you are most proud of, David?
So the thing I'm most proud of professionally is the thing that I enjoy the most. You know, I joined a legacy practice in my hometown in Tampa Bay, and the practice was an excellent clinical practice, like a lot of places in the country where there were a lot of patients, a lot of pathology, a lot of good work being done, but there had not been a clinical trial enrolled since the COM study. And similar to your professional experiences, I built one of the largest clinical trial programs in the United States from the ground up, which I continue to foster. And I see it now kind of reaching adolescence. And it's very gratifying to feel that you're not only helping patients on Main Street, but you're helping the field as a whole. And doing that from the ground up has been and continues to be a really great source of professional gratification.
You have done a great job, David, and not only just creating this great clinical research site, but also having recruiting, great physicians to your practice and kind of expanding it in a way that you're actually contributing to bring new treatments for our patients, broadly. And I think, building something from ground up, I've done the same thing. And I think it's very satisfying when you see that the work we did over the last 8 or 10 years actually led to multiple approvals, right, of new drugs and devices for retinal diseases that people around the world are now using. I think I tell, younger doctors that clinical research is so rewarding because you can make an impact to millions of people around the world, not just at one patient at a time that you do in clinic. I think doing both is so phenomenal, and I think you've done an amazing job leading that. And then, you're still kind of in mid-career like I am. We still have a long way to go, but in terms of how do you want to be remembered once you retire? I know it's long time from now, but what are, when people talk about David Eichenbaum, what do you want to be remembered as?
Geez, I mean, retirement. We don't even think about retirement. You know,
Right.
I have a fiscal retirement plan, but no professional retirement plan. But that being said, like you stated, in mid-career, we see things with our colleagues and with our mentors, and time retires everybody eventually. So it's a good question, and it's apropos. I think that the thing that would make me most happy is for people to think of me as a friend to the field and someone who lifted up retina specialists who were junior to me. I think that a rising tide lifts all ships. I see a lot of practices where the person who runs the clinical trial department or the person who runs the academic department doesn't seem to do enough to promote and elevate junior retina specialists, either in their own practice or in practices around the country. And what really makes me very happy is helping other retina specialists achieve their career goals. I love doing that in my own practice. It makes me very, very happy to do it with doctors who work with me, but it makes me almost as happy to do that with doctors who I meet and doctors who I work with around the country and around the world.
I think that's very rewarding for sure. I think I totally agree with you. I have fellows that I train, and then you see somebody who comes in without much knowledge or much surgical skills, and you see them after 2 years, and they are great clinicians and great surgeons, and then they learn a lot about clinical research. No, what I love about you, David, is that you are the most collaborative of all of us. I think our generation, we all help each other in terms of becoming better. And I
Mhm.
think that's the key, that I think the learning never stops and we all continue to learn. And I think if we learn together, we end up having better outcomes for our patients and new treatments by collaboration. So thanks again, David, for being here, for excellent discussion. I want to thank the audience for listening in. Please remember to take the post-test and evaluation to receive CME credit, and to tune in for additional episodes within the podcast series. Thanks again, David.
Thanks, Arshad. Pleasure to be here, and it's a real treat to talk with you.